Hello everyone, welcome back to Connect Radiology. So, this is episode 4 of our liver series, and we'll be discussing a very important topic that's nodules in cirrhotic liver. So, let's get started. So, in this video, we are going to discuss about the various nodules of cirrhotic liver. So, these are the regenerative nodules, low grade dysplastic nodules, high grade dysplastic nodules, early HCC, and finally progressed HCC. So, all these cirrhotic background nodules actually differ at their genetic molecular levels on the basis of their histopath, and they can occur in continuum like regenerative to low grade to high grade to early HCC to finally progressed HCC, and they can also be not in continuum like low grade dysplastic nodule directly giving early HCC and so on. So they can be like in continuum or they can not be in continuum, and they differ in their genetic basis at the molecular level, at the histopath level. But we as radiologists, we have to differentiate all these lesions because we have to treat the patient then accordingly. Like for example, regenerative nodules are benign nodules, while from this dysplastic stages there is some sort of dysplasia, then early HCC just like carcinoma in situ stage, and finally the progressed HCC. So let's look at this chart of the CT and MR features of these nodules of cirrhotic liver background. So first are the regenerative nodules, or also called as cirrhotic nodules. Just remember the word ISO for them, okay? So they are ISO on non-enhanced images because they are just like normal hepatocytes, okay? Just remember them as though there is a difference at the genetic molecular level, but for the sake of imaging, just remember they are like another hepatocytes. So they're on unenhanced CT, they're ISO. On T1 images, they're ISO. On T2 images, they're ISO. On diffusion, they are ISO. On arterial phase, they are hypo. There is no angiogenesis, so they just take up the contrast as that of the rest of liver parenchyma. On venous phases also they are ISO, but they can be hypo also because sometimes they are taking lesser contrast as compared to the background liver. So in the enhancing background of liver they appear as hyponodules. And on MR imaging with the hepatobiliary agents on hepatobiliary phase, there are again ISO because they contain the hepatocytes having OATP. So they are like ISO intense on the hepatobiliary phases, okay? But remember they can be hyper also. So just remember the usual findings, okay? There can be exceptions always. So these T1 on T1 weighted images, they can be hyper also because of some reasons unknown. They can be T2 hypo also because of unknown reasons. They are usually ISO on hepatobiliary phases because of the hepatocytes, but they can be hyper also. Why hyper? Because just remember that sometimes the liver, adjacent liver is very cirrhotic, and they don't have enough hepatocytes to take up the contrast as compared to these regenerative nodules which have the hepatocytes, so they take up the contrast, and they are like slightly hyper in the hypo background, or sometimes they have enough hepatocytes to take up the contrast, so they are hyper, but they don't have enough hepatocytes to excrete the contrast, okay? So they remain as hyper, all again they can be hyper also, okay? Some other things about these cirrhotic nodules is that sometimes the liver is so cirrhotic that they have more water content as compared to the surrounding liver parenchyma, and as they have more water content, they can be like hypo on non-enhanced images. Because of more water content, they can be T1 hypo and T2 hyperintense, and they can have fat within them, so can be like T1 hyperintense. So all the permutations, combinations are possible, but just remember the usual thing, that's ISO. They are like always ISO. Okay, so these are the cirrhotic nodules. Next are these low grade dysplastic nodules. Okay, the low grade dysplastic nodules, they can be like iso, hyper on non-enhanced images, or they can be hypo if fatty. On T1 images, they can be hyper or iso. Hyper, depending on the what agents they have within them, like copper, iron, so they can be T1 hyperintense also. They can be T2 iso or hypo, diffusion iso or hypo, arterial phase hypo or iso, venous iso, hypo, and hepatobiliary phase iso. Just remember, for dysplastic nodules, they are never T2 hyper, they are never diffusion restricting. Okay, just remember these things. Dysplastic nodules are never T2 hyper, and they are never hyper on diffusion, they never restrict. Okay, so these are the low grade nodules. Similarly, for high grade nodules, can be iso, hyper, hypo, T1 hyper or iso, can be T2 iso or hypo, can be diffusion iso or hypo, but never T2 or diffusion hyper. Okay, from this high grade stage, okay, there is some angiogenesis, so they can be really hyper also on arterial images. Then next, what we have to do, we have to look for the venous phases. We all know the basics. HCC shows arterial hyperenhancement, and then washout on portovenous phases and an enhancing capsule. But for example, if the high grade dysplastic nodule is showing hyperenhancement, they won't show hypo, means they won't show any washout on portovenous phase, or they won't show any capsule. Okay, so just remember this. And from this stage, as they have there can be angiogenesis, so this arterial hyperenhancement, there is lesser OATP, so there can be hypo appearance on the hepatobiliary phase. So this differentiation is like occurring from this high grade dysplastic nodule stage. Okay, next is this early HCC stage. So again, there are different permutations, combinations, but this as HCC carcinoma has occurred, so they can be like T2 hyper, and they can show diffusion restriction. From this point, T2 and diffusion are the main differentiating points. And also again, they can be like show arterial enhancement, but from this stage there will be washout, there will be capsule presentation. Okay, and they will be like hypo on this hepatobiliary phases. Okay, from this early HCC stage, arterial hyperenhancement, washout is there. Okay, next is the progressed HCC, all the full-fledged HCC. We all know T2 hyper, diffusion restricting, arterial hyperenhancement, washout on portovenous phase with capsule, and hypo on hepatobiliary phase because they don't have enough hepatocytes. Okay, as I said, exceptions are always there. The cirrhotic nodules even can have arterial phase enhancement, and for example, the cirrhotic nodules or dysplastic nodules may undergo infarction and thus can appear T2 hyperintense or diffusion restricting. But remember, for the general rule per se, the basics you should know. Okay, so role there is a role of this T2 and diffusion, because till the stage of high grade dysplastic nodules there is no T2 or diffusion restriction, but the high grade dysplastic nodules show arterial phase hyperenhancement, and but they won't show the portovenous and delayed phase hypoenhancement and the capsule. But this washout phase is very evident from the early HCC phase only, and this hepatobiliary agent help in differentiating the regenerative cirrhotic nodules and low grade dysplastic nodules versus the high grade dysplastic nodules and early HCC. Okay. Just like say lack of arterial phase hyperenhancement can be there in early HCC also. Okay, so for the lack of early arterial phase hyperenhancement, we have all the four differentials: the regenerative, low grade, high grade, and early HCC. All these can be arterial phase show lack of enhancement. Then how to differentiate? By the hepatobiliary agents. The first two are iso because they have enough hepatocytes, and the high grade and early HCC don't have enough hepatocytes, so they are hypo on hepatobiliary phases, but these can also be like iso. Okay, so remember the exceptions are always there. Another variety is this cirrhotic nodule. Okay, these cirrhotic nodules, because they have iron within them. These are the subcategories of dysplastic nodules having iron within them, so they are hyper on unenhanced CT. They can be hypo, iso, or hyper on T1 depending on the T1 and the amount of iron. They are T2 hypo, okay, because of the T2 star shortening effects of iron. They are diffusion hypo. They are iso hypo on arterial phase, iso hypo on venous phases, and but on the hepatobiliary phase they are hypo, not because they don't have hepatocytes, but because of the iron which has this T2 star shortening effects. Okay, so and again one thing that a fat, okay, fat can be there in any of these nodules, but fat, intralesional fat, is more in favor of HCC. And another category is that nodule in nodule appearance, for example in a cirrhotic nodule. Okay, cirrhotic nodules, within this cirrhotic nodule focus of HCC can develop, like within an iron rich nodule there can be like iron poor subnodule. Okay, and this is nodule in nodule architect, and these raises the concern for HCC. Okay, so I think you can remember the usual findings because exceptions are always there. Just remember these 4 steps of T2 diffusion. Okay, not there till dysplastic nodules, arterial in high grade dysplastic, but no washout, no capsule, and the hepatobiliary agent showing hypoenhancement from the stage of high grade dysplastic nodules. So thank you so much everyone. We'll see in very much detail about HCC and LIRADS in our next video. So stay tuned and thank you so much.